Hi, I'm Dr. Wendy. I'm a senior pain physician in Hadassah University Teaching Hospital, and I lead the treatment of musculoskeletal pain in the pain unit. I'm giving a series of lectures on prolotherapy, platelet-rich plasma. The principles which I'm going to present can actually be applied to both methods of treatment. So before I go on with this lecture, I've got a picture here which is going to be the background of most of the slides in this lecture. And I want to ask you, what is this picture of? So you can see parallel fibers that are beautifully, nicely aligned and very regular, with a few fibroblasts in between, with no blood vessels here in this particular image, in this particular screenshot. And there are blood vessels far and few in between in this tissue. So this is a section of type 1 nice collagen tissue which can be found in either tendon or ligament. They are slightly different, but this is basically very similar to both. So regenerative injection therapy is a completely different paradigm to what we're used to. Our body is loaded with pharmacology to heal, and we just have to know how to give ourselves the right push in the right direction to enable these regenerative injection therapies to work. So there are various types of injection therapy. There's first the simplest and the cheapest is hypertonic dextrose injections with concentrations varying between 12 and 25%. And these incite the body to manufacture growth factors. Platelet-rich plasma injection is based on the fact that platelets are filled with granules which are in themselves full of growth factors which are just ready to act. And stem cell injection includes various treatments such as bone marrow aspirate injection. Sometimes the aspirate can be concentrated and that can be injected, or injection of mesenchymal stem cells coming from adipose tissue, which has been found to have many benefits over the bone marrow injection. So many of our patients feel that they're falling apart, their arms, their legs are falling off, they're not functioning well. And some of these patients complain of so much pain, they can't deal with it. Doctor, please take my arm off, my leg off. They say it jokingly, but we want to transform these patients using an anabolic process into fully functioning units where all the systems of the body and all parts of the body are coordinated perfectly. And I really believe that within 1 or 2 decades, corticosteroids will be history in terms of treating musculoskeletal degenerative disorders. They'll probably be used for the treatment of severe florid inflammatory joint disease with very, very inflamed synovia. But apart from that, I believe it'll be out of practice. It'll be history. So what is prolotherapy? The word prolotherapy is derived from the word to proliferate. In the 1940s, the 1950s, the 1960s, when prolotherapy was started by George Hackett and then continued by Hemwell, prolotherapy injections and solutions were much, much more aggressive than the dextrose that's used today. And these previous solutions used to incite a very, very florid inflammatory response. And these were injected with the intention of causing the body to lay down scar tissue, which would heal defects in various tissues. But today, most prolotherapists use hypertonic dextrose, and this is much simpler, less painful, both during and after the treatment, and safer. So the most important central tenet for the treatment, to get a successful long-term treatment result depends on doing a methodical, comprehensive evaluation. And that applies to any treatment, but particularly with musculoskeletal medicine, when we have so many biomechanical factors coming into play and one's compensating for the other. So no matter what your treatment is, if you don't do a methodical, comprehensive evaluation and apply the treatment accordingly, then you're not going to get a good long-term result. Now, when you have a particular stress, chronic stress such as a faulty posture or faulty ergonomics that is applied to an area, it doesn't fall on one tendon, it doesn't fall on one joint, it falls on a region. If someone falls, you don't injure normally just one tendon. You injure a few tissues. Maybe one structure will suffer the most, but the whole region suffers somewhat. And when something is injured, then the surrounding tissues are recruited, especially the agonists are recruited to try and help that function. So if all that is failing, is all that is under this stress, and the stresses, if they continue, are going to be applied to this area, are going to continue, then the rest of the function, the rest of the unit is going to suffer eventually, is going to succumb eventually also. So in other words, first of all, we must treat the whole functional unit. We have to think rehabilitatively and not just one-shot treatment. And we have to address, if possible, to try and minimize faulty ergonomics, faulty postures, which isn't always possible, but at least to try. And especially if we can't change that, then at least to strengthen the surrounding structures as well, so that this whole region will be able to withstand the forces that are applied to it. So this is one of the major advantages of hypertonic dextrose injection compared to platelet-rich plasma. Because if you're going to inject the surrounding structures as well as, for instance, an intra-articular injection, that needs a lot more volume. And that makes, if you're going to use platelet-rich plasma, that can be exorbitantly expensive for patients who cannot afford it. Buckminster Fuller was a very famous architect who coined the term tensegrity. And tensegrity is actually a combination of two concepts, tension and integrity. So the model in the top middle is a structure which is comprised of rods and connecting sort of elastic bands. And if you can imagine that you're going to pull on one of those elastic bands, that whole structure will be deformed. If one of those elastic bands is broken or flimsy, then also the whole structure is not going to stand properly. It's going to be deformed. And so with every animate and inanimate object has a certain structure that's based on a tensegrity model. Even the cell on the left-hand side here, the structure is formed by all sorts of connecting proteins that give it this form. With a building, if you're going to have one part of the building falling and it's not going to be strengthened and it's not going to be repaired and the areas next to it aren't going to be strengthened, then the whole building is going to collapse. And the part of the body to which the tensegrity concept applies the most are the sacroiliac ligaments and joints, because this area functions like a sack, like a basket. Its role is to transmit the weight of the upper body down to the limbs on one hand, and on the other hand to shock absorb from the ground down upwards. So if you're going to have some ligaments that are loose, then the joints are likely to subluxate and cause instability, a sensation of instability when the patient's walking. Or on the other hand, if the ligaments are tight or the joint is stenosed, as like many orthopedics like to treat in order to treat sacroiliac pain, then you're not going to get the shock absorption which is necessary, and then the surrounding structures suffer more. So how does prolotherapy work? There are a few mechanisms that work together. The osmotic effect, the immune effect, when monocytes, type 2 monocytes are recruited, and these manufacture anabolic cytokines, which in themselves lead to recruitment of fibroblasts, which manufacture collagen. So when you're getting deposition of collagen and strengthened tendons and ligaments, then one's starting to function better and walk around better and mobilize better. And these mechanical stimuli in the cells lead to further repair and further improvement of function. In addition, there's a neural effect, or there are hypotheses that that dextrose may actually work as a neuromodulatory effect. So all these mechanisms are working together. Now, when we use prolotherapy, and we can use the same with platelet-rich plasma, we usually direct the needle to bone, touch bone, and we withdraw a little bit, and we redirect a little bit, and withdraw and redirect, and then come out, and then not completely, and then go the other way. And what happens is you get a little bit of bleeding, and so the platelets are recruited. And this whole graph actually, which represents the healing process after trauma, actually is said to apply to prolotherapy and platelet-rich plasma injection as well. So you get platelet activation, and you get granulocytes recruited, and slowly monocytes, type 2 monocytes are recruited, and which release anabolic cytokines, which in themselves lead to the recruitment of fibroblasts and laying down of collagen. Now, it's not a simple approach here, a simple stage here, which starts at about 4 or 5 days of recruiting fibroblasts and laying down collagen. But this lasts up to a year, but it goes through several phases of proliferation and remodeling and repair. So we start off with type 3 collagen, which is a weaker temporary sort of collagen, and this is gradually replaced by type 1 collagen, which is permanent, strong, and much more able to resist various stresses. The growth factors have various functions for forming extracellular matrix, for angiogenesis, for collagen synthesis, for collagen remodeling, for collagen cartilage and muscle repair, and also for skin repair. So these growth factors are said to be incited with prolotherapy, and in PRP are ready to act. So there are advantages with both methods. In terms of the literature with prolotherapy is relatively scarce, but it's improving. About 8-9 years ago, when I looked in the literature to see how many publications there were in prolotherapy, there were a total of 192. Today, there's 312, which isn't a huge amount, but it is improving. With platelet-rich plasma, there's a lot more. There's over 14,000. Platelet-rich plasma seems to be a much more attractive sort of therapy popular among orthopedic surgeons in particular. But prolotherapy should not be knocked at. It has several advantages. It's cheap, it's easy to apply, and one can easily do a much more methodical treatment, as I talked about before. So the first of the studies that I'm going to present is one published by Yoshi in 2014. He also published in 2009 and 2011, where he took the transverse carpal ligament. He injected the transverse carpal ligament of rabbits on each side of the rabbit. With one side, he injected 10% dextrose, only 0.1 cc, and the other side, he injected 0.1 cc of normal saline. And 16 weeks later, he reviewed these under microscope, and he showed that the ligaments that were injected with dextrose were much thicker than the ones that were injected with normal saline. In addition, he applied various forces to these ligaments to see what force will lead to rupture of the ligaments. And he found repeatedly in 2009, 2011, 2014 that the ligaments that were injected with dextrose required much higher forces to lead them to rupture. Shan did a case series of 43 patients with partial Achilles tendon tears, and he injected them once with hypertonic dextrose into the tear under ultrasound, and he followed them up for 12 months. And at the end of 12 months, he found that 30 of them had improved visa function scores at 3 months, and 40 points at 12 months follow-up. In addition, he looked at these tendons under ultrasound 5 weeks after the injection, which I think is way too early. We just talked about how the whole remodeling process takes months up to a year. But he did this 5 weeks after the injection, and he found that 9 of these patients had absolutely no signs of tear. Alicia Johnson did a very interesting study in which he took chondrocytes from distal femurs of people who were undergoing total knee arthroplasty. And he incubated these chondrocytes in petri dishes with various concentrations of dextrose, ranging from 4 millimolar to 260 millimolar. And what he found was that the chondrocytes that were incubated in petri dishes with 250 millimolar dextrose replicated the most. In addition, the metabolic activity peaked in the petri dishes with concentrations of dextrose of 250 millimolar dextrose. He compared the chondrocytes that were incubated in the petri dishes with 250 millimolar dextrose with chondrocytes that were incubated in petri dishes with mannitol and with saline. The mannitol also being in hyperosmotic concentrations with the same osmolarity as the 250 millimolar dextrose. And he found that the chondrocytes incubated in the dextrose solution produce much, much more collagen per chondrocyte over 24 hours than in the other petri dishes. In addition, he found that they proliferated much more than those in the other petri dishes. By the way, you can see that the background here from the last slide and this slide and the next couple of slides is of cartilage. You can see the nice chondrocytes, healthy, and a lot of nice extracellular matrix in between. This is an interesting study published in 2016 by a guy called Topol, in which he took only 6 patients, but they were with arthroscopy, so that explains why. He took patients with grade 4 osteoarthritis. And the reason he did this is because he wanted to see if cartilage will grow on what was previously denuded bone of cartilage. And so what happened is he took these patients and he got an independent orthopedic surgeon who did an arthroscopy on all of them before treatment. And during the arthroscopy, he stained the cartilage with methylene blue. And also he took biopsies. After the arthroscopy, all the patients received 6 injections a month apart of hypertonic dextrose into the joint. And after that, they had a repeat arthroscopy to see, with methylene blue staining and biopsies taken, to see if there was any changes in the cartilage. And you can see here in the picture taken, arthroscopy taken prior to the treatments, you can see that this is of the medial femoral condyle. You can see that here, there's very little cartilage here. And exactly the same view, exactly the same part of the medial femoral condyle, you can see that there's areas of cartilage that have grown and over areas that were completely bare of cartilage. So from this section, 2 biopsies were taken, and this is a picture of one of the biopsies showing very nice healthy cartilage with chondrocytes in between and a lot of extracellular matrix in between. And that actually shows that dextrose has the capability of inducing the growth of cartilage over bare bone. This is about a meta-analysis published by Wang, also in 2021. Only of 5 studies which met his criteria. And these 5 studies, in all of these studies, patients were injected with intra-articular dextrose and were compared to controls of either intra-articular saline or exercise. And all 5 studies show dramatic and significant improvement in those who were injected with dextrose compared to the controls, both regarding the WOMAC function scores as well as the pain score. This is an interesting study published in 2019 in which patients were injected in which dextrose was compared to platelet-rich plasma injections. So there were 44 patients in total, 22 in each group, and all the patients were given 1 injection of either hypertonic dextrose or platelet-rich plasma. And one can see that in both groups, the post-treatment 6-month treatment scores were significantly much improved compared to the pre-treatment scores, but the platelet-rich plasma patients did improve more. And that's concerning both the WOMAC scores, where the scores fell dramatically, and also the pain scores, where the post-treatment scores were significantly lower at 6 months compared to pre-treatment in both groups, but more significant in the platelet-rich plasma group. So the flip side of the coin, intra-articular steroid injections. How many times have the orthopedic surgeons are starting to come out again and again and again, recommending not to inject intra-articular corticosteroids? Providers should be aware of the adverse effects and potential complications of these injections when using them in clinical practice. Triamcinolone reduces viability, induces oxidative stress, and alters gene expressions of human chondrocytes. Regarding tendinopathies, glucocorticoids have been found to induce ion channel-mediated toxicity in human rotator cuff tendons. And in The Lancet in 2010, a meta-analysis was done comparing various therapies for the treatment of various tendinopathies, in which platelet-rich plasma, prolotherapy, steroids, and hyaluronic acid were compared. And steroids did show short-term improvement, but patients who were injected a second time or a third time, many of the studies showed that they were worse off after the second or the third treatment than they were prior to the first treatment. Whereas the prolotherapy and platelet-rich plasma injection treatments usually did better or got positive results. This is an interesting study by Chloe Wernicke, who recognized the beneficial effects of steroids with an anti-inflammatory effect, but that the recommended dose for a single intra-articular injection is between 2 and 3 milligrams of methylprednisolone or triamcinolone, compared to the average 40 milligrams that orthopedic surgeons often use, and sometimes even more. And if you're going to have a few injections, then the cumulative dose should not be more than 8 to 12 milligrams, which is a far outcry from what's done today. So what are the indications for prolotherapy or platelet-rich plasma injections? Chronic musculoskeletal pain, tendinosis, partial tear of a ligament or a tendon, ligament instability, and osteoarthritis. So what are the contraindications? First of all, sepsis, especially if it's generalized. Autoimmune disease. If someone has a florid autoimmune disease, a really severe inflammatory joint disease, they will not be happy campers if you inject them with 25% dextrose. And someone who has severe hypocoagulation or is on anticoagulants, to inject around their spine, I would call that an absolute contraindication. Someone with a significant neurosis or any very obvious psychopathology is unlikely to improve with regenerative injection therapy unless they have a lot of psychological help together with it. And someone who's taking chronic steroids chronically is just going to neutralize any effect that you want to achieve with regenerative injection therapy. So what are the 5 Ps of prolotherapy? And by the way, with platelet-rich plasma, first of all, prepare the patient before you inject. Tell them what you're going to do. Position the patient and position yourself. Look after your own ergonomics. Think about the points you're going to inject, where they are, how many of them, and how you're going to tackle them, from what angle. And also make sure that you know what not to inject, how to avoid the lungs, the intraperitoneal area, intrathecal area, and also how to avoid nerves, not to cause nerve damage. So what solution do you inject? If you're going to inject intra-articular to tendons or ligaments, then the basic rule of thumb is to always touch bone, unless you're injecting intra-articular or into a tear, which you would do under ultrasound. So you inject between 12 and 20% dextrose, depending on the method you're choosing, and between 0.3 and 0.5% lidocaine after it's been diluted. So if you're going to inject 20% dextrose, you take 4 cc's of 50% dextrose and dilute it to 10 cc's, with the 6 remaining cc's, in which would be probably about half lidocaine, half normal saline, or if you want to use the whole 6 cc's with lidocaine. Bear in mind that if you're doing this repeatedly, lidocaine has been found to be toxic to tenocytes as well as chondrocytes. So I try to be sparing with it, unless someone has a very low pain threshold and needs a local anesthetic. If you're going to inject 15% dextrose and you use 3 cc's of 50% dextrose, also diluted to 10 cc's. When I came back from my first course in prolotherapy 12 years ago, we were taught to inject 15% dextrose. But I came home to Jerusalem and by accident I injected 20%, and I found such good results. Since then I've been alternating between 15 and 20% dextrose. If you want to inject intra-articular, then 25% dextrose is the recommended concentration to use. And the volume you inject really depends on the joint you inject. If you're injecting the knee, then you inject about 5 cc's, the same with the hip, and obviously less if you're going to inject smaller joints. The injection technique. So as I said, you inject intra-articular, always touch bone unless, and I can't emphasize this enough, unless you're going to go intra-articular or into a tendon tear. The reason is it's safe. You know that you're in safe territory when you're on bone. When you touch bone, then you make small changes. You pepper. You touch the bone, you pull out a little bit, not all the way, and you redirect a few degrees, and you pull out, and then you redirect again and go medially, and you pull out, and then you redirect and you go laterally, etc., and maybe superiorly and inferiorly. And depending on the region, on the area that you're going to inject, you can decide how many times you're going to pepper and what volume you'll inject in total. But at each peppering point, you would inject about 0.3 cc's, that's all. So a total of all the peppering points would be about 1 cc, 1.5 cc's. If the large area like the sacroiliac ligaments, you could inject 2 cc's. Especially if you're doing this landmark approach and not under ultrasound, and you're having the patient, you're doing treating the patient's back with him lying on his tummy, then when you mark out the back and you find your landmarks, patients lying on their tummy often move around, they wiggle around. So the landmarks that you would find after they wiggle around may well and probably will have changed markedly. So if patients move around, palpate and palpate and palpate again, unless you're using ultrasound. And for patients who have very low pain thresholds, you may consider EMLA cream, but this takes about an hour and a half to take effect. So what can patients expect after a treatment? minimal pain to mild pain for 2 or 3 days is the norm. Some patients have pain up to 6 days. But generally, people who feel pain, you can prescribe them paracetamol or low doses of paracetamol and codeine mixtures, or paracetamol and tramadol mixtures like Zaldiar. And how often? The ideal is to give a treatment every 3 to 4 weeks, but the treatment intervals can be longer, and to do about 5 treatments in the period of about 12 months. And then maybe 1 or 2 maintenance treatments a year if necessary. And most patients manage with that. And this is ample for most patients. In my clinic where I work in hospital, my appointments are about 4 to 5 months apart. And patients are lucky to get appointments for every 4 months or 5 months. So most patients get about 2 to 3 treatments a year, and most patients manage with this. And if someone really wants more treatments than what I've mentioned here, recommended here, then I would refer them on to platelet-rich plasma injections. So, very important, if you want to get good results, long-term results, not to forget the posture and the ergonomics, and change it as much as you can. If you look at this guy on the top left-hand side, you can see he's got a very much of a C-shaped spine with a head-forward posture. And he's putting a lot of stress, a lot of stretch on those muscles here, on the thoracic muscles, on the extensor muscles, on the facet joint capsules, on the muscles of the neck, and the facet joint, and all the ligaments of the neck. Now, the average head weighs about 4.5 kilos. And if you were to take a 4.5 kilo weight in front of you and just hold it there for 10 minutes, you're not going to be very happy. That's going to be painful and sore. And just think how much energy we expend. And we don't blink an eyelid when we see people like that, or when we sit like that. It's just so much of the norm these days. But patients who are going to have neck pain and going to continue sitting like that are not going to get good long-term results, because they're just undoing anything that we do for them. Dentists are notorious for suffering from neck pain, and you can understand why in the positions they get into. When you want to lift up something, don't lift up something on the oblique, because the muscles are not conditioned to function that way and to carry that weight, or to carry your spine up in many people, especially people who have weak back muscles. But if you want to lift up something, even if it's a piece of paper, you turn towards that object, you come closer to that object, you bend your knees and you pick it up. Sleep. How much this is ignored. How many of our patients complain of pain that gets worse during the night and is worse in the morning, and during the day it gets better. And how many of us ask, well, how did you sleep at night? And I'm not talking about the quality of sleep, but what position did you sleep at night? What's your pillow like? What's your mattress like? So if someone sleeps on his or her tummy, and we're not sleeping on a chiropractor's treatment table where it's got a hole in it, we can put our head straight through. We're rotating our heads around 70 degrees, and not for a few seconds like we do in the gym. We're not stretching those muscles and ligaments for just a few seconds. This is for hour upon hour, every day, every night, which puts a lot of stress on the facet joint capsules, on the muscles of both sides. And if we're going to treat a person with neck pain, we're not going to expect long-term results if she's going to undo the treatment that we're doing. We're lying on the side with the upper hip flexed forward more than 90 degrees, with the hip adducted down right onto the bed. We're stretching the gluteal muscles. We're stretching the sacroiliac ligaments. We're stretching the lower facet joint capsules. And this is continual, hour after hour, night after night. Again, we'd be undoing all the treatment, all the sacroiliac joint treatment and injections that we get. So if we want to recommend a good treatment, to lie on the side, if you're going to lie on the side, to first of all not flex the hips too much, not more than 90 degrees, and to put a pillow between the legs, especially for women who have a very much of a pear-shaped posture with wide hips, because when they lie on the side, the upper hip is very much adducted. So you want to put a pillow between the legs. And in terms of the neck, not as it's depicted in this picture, you want the head absolutely 180 degrees level with the body. So we're not putting any strain on the lateral side of the neck. And we're lying on our back, a small pillow underneath the neck. So we're not flexing our neck too much forward. And maybe, if necessary, a pillow underneath the legs. So we must recognize that our body is loaded with its own pharmacology to heal. And we want our patients to really function as one happy unit with everything, all the structures coordinated together in perfect synchrony and swinging back into life. So thank you for listening. If you have any questions or comments, please note down below. All the best.